that I have produced based on the World Health Day message that the World Health Organization has given. And what the World Health Organization is saying is that our world is an unequal one. And I've just summarized some of the key points that they've highlighted. Especially during the COVID-19, I think this has become very clear that some people are able to live healthier lives and have better access to health services than others. And for example, here in the UK, we are very lucky to have the NHS, which gives us a lot of good care. And we've seen this during the COVID-19 crisis. And many of us are very lucky to have access to healthcare. But there are people around the world who do not have this luxury. And indeed, some groups actually struggle. They have low income, poor housing, live in overcrowded houses. They have poor education. They don't have many employment opportunities. They experience greater gender inequality, have little or no access to safe environments or clean water and air and food. And so they have a lot of issues related to access to health, and health inequality is a big issue. And this is not only unfair, it is actually preventable as well. And around the world, COVID-19 has been harshest on those communities which were already vulnerable. So even in the UK, we've seen that certain groups have been more vulnerable than others in terms of higher incidence of COVID-19, infection rates or mortality and severe cases of COVID-19 and so on. So the world that we live in is really an unequal one, and more needs to be done in order to find solutions to all of these things. And one of the things that I feel is very important to consider is also the issue of looking into. Sorry, I just have to get the next slide here. One point I like to really point out that one size does not fit all. And this is an issue that we really need to think deeply about, because now we have access to big data. We have huge amount of data. Data is everywhere. And we also have advances in technology, computer science, statistics, and mathematics. So we can apply artificial intelligence to go beyond ways of looking at data by putting them into certain boxes, which often does not really do justice to the subject. We divide things according to ethnicity, according to geography, region that one lives in. We divide things by gender, we divide things by age and socioeconomic background. While all of these things are useful, but often they miss out a lot of important information, because within one ethnicity, you may have lots of differences between access to healthcare, poverty, job opportunities, and so on. So you need to go beyond this one size fits all approach. And one of the things that really makes me think and wonder is that if you can use artificial intelligence to search for life in distant planets, and I have a reference here where NASA has artificial intelligence approaches being applied to look for life in other planets, surely we can use big data and artificial intelligence to identify those people who are at most need for help and provide solutions for health needs and health priorities based on data and identifying those who are most in need. Instead of using ethnicity, we need to go beyond these different identifications based on ethnicity, geography, gender, age, and socioeconomic background, and use these huge volumes of data that we have and artificial intelligence to address ill health and inequalities in our society. So in today's presentation, we have 3 different lectures from Montfort University. These are people who have extensive experience in different areas related to the impact of COVID-19. And one of the first lecture is to be delivered by Sasha Loyal, who is from the Center for Reproductive Research. And she's going to be talking about the impact of COVID-19 on reproductive planning and experiences. Thereafter, there will be a lecture by Ross Little, and his lecture is entitled "The Health of Children Subject to Solitary Confinement in Prison." And finally, we'll have a lecture by Ngosa Kambashi, and her lecture is about a mixed methods study of professionals, survivors, and community perceptions of male rape. So she's from the Institute for Psychological Sciences. So we have 3 different presenters today, and we are really excited to hear from them, and we'll have an opportunity to ask questions at the end. Before the question and answer session, we'll have a panel discussion, and we really like to hear your questions if you have any. So please do not hesitate to send in your questions through the online system. So without further ado, I will pass on I'll pass on to Sasha Loyal, who is going to be speaking about baby bust.
Thank you, Parvez. Thank you for that introduction. So my slides. Thank you. So thank you very much. My name is Sasha, and I'm a PhD student at the Centre for Reproductive Research. And today in this very short presentation, I'm going to be discussing the impact that COVID has had on women's and couples' reproductive lives. At the start of the pandemic, a year ago now, there was a lot of commentary about a suspected baby boom. Couples are spending more time than ever before, leading people to think that there would be a rise in pregnancies and maternity services would be overrun by the end of 2020. But these conversations have now changed, and what is now being predicted is in fact a baby bust, with people delaying or abandoning childbearing plans altogether. So this presentation is going to provide a snapshot of the complex ways in which the pandemic has affected various aspects of childbearing. And I'll be drawing on my PhD research, which focuses on how women evaluate the ideal timing of motherhood. I'll focus on how the pandemic has shaped individuals' decision-making and experiences, and including the ways in which COVID has disrupted fertility treatments and access to contraception, all contributing to these conversations about why there may be more likely to be a baby bust. I wrote about the impact of COVID on fertility timing last June, and didn't think that we would still be in close to lockdown measures over a year later. So the impact, but we can still see that the impacts of the pandemic on family life, health, the economy are still unfolding. And a lot of these effects are predicted to last after the vaccine rollout. So very quickly, my PhD focuses on questions of reproductive timing and when women feel is the right time to have children. And we know from this body of research that questions of when to have children are shaped by a number of social and cultural factors, economic factors, and individual desires. My research shows that women have a desire to accomplish a number of milestones before having children, such as a career, financial stability, having a home, feeling psychologically ready, physically ready, and all of these factors are considered necessary to perform the role as a parent. But all of these factors have been impacted in some way by COVID, and I'm going to whiz past these in the interest of time. So in my study, I found that many women wanted to have financial and economic stability before starting a family. We saw that last year unemployment levels rose considerably, working hours reduced, and recent research suggests that individuals are delaying or completely abandoning their fertility plans as they expect the crisis will have a negative impact on their future income. We also know from research and from my PhD that women want to feel a sense of readiness, a sense of mental readiness before having children. We've seen that the pandemic has had a negative impact on individuals' mental health, which has been exacerbated by the limited access to social support and healthcare, which may lead women to and couples to delay childbearing until they're in a less precarious environment. Career trajectories have also have been negatively impacted. Getting ahead in a career before starting a family was also very important for women in my study. However, the pandemic has had a negative impact on career trajectories, opportunities for new jobs and promotions. What was quite evident in my study as well is that marriage is very important for many women before having children. But we've seen that the number of marriages that have been postponed last year because of the pandemic. And this is likely to have a downward influence on fertility rates. Family life has also dramatically changed. We've seen that people are spending more time at home, and existing parents have the additional pressures of childcare and homeschooling. Therefore, the additional children may not be on the cards for some existing parents due to their current childcare responsibilities, and who also rely on family and friends for childcare support. Current guidance states that women who catch COVID may be at an increased risk of becoming unwell compared to non-pregnant women. And there have also been higher rates of admission to intensive care units for pregnant women in comparison to non-pregnant women. Couples may therefore decide to postpone having a baby due to concerns about the risks of COVID on the pregnancy. And research also suggests that individuals are worried about overwhelming the NHS. We've all heard, we've been kind of ingrained with that message of save the NHS over the last year. And research has shown that that's really been embedded into people's decision making around when to have children. Hospital visits and checkups are routine during pregnancy, and there are also concerns about the potential exposure to COVID during these visits. And finally, social and healthcare support has been kind of massively impacted. The lack of social and childcare supports from family and friends as a result of lockdown and social distancing rules, but also the limited access to healthcare, which are provided as routine during pregnancy, such as perinatal services, NCT classes, which are likely to concern individuals who may be thinking about starting a family and are worried about the quality of care that they might receive. We also know from kind of history that economic and health crises have never been kind of preferred periods for couples to have a baby. Just looking at Spanish flu and the Zika epidemic and other periods of economic downturn, these have always been followed by a kind of fertility decline, and they all have different features, but also have that have the same kind of impact on people's decision making. Finally, just to kind of nod into the other ways in which COVID has impacted women's decision making who are planning not to have children, and those who are planning to have children but through assisted reproductive means. The pandemic massively disrupted the NHS, as we know, and sexual health clinics that provide contraception for women. And still to this day, nearly a year later, many clinics still have reduced services, which are leading to continuing disruptions around the access of women's usual methods to contraception. And this varies across different hospital trusts, but still today there are these clinics have kind of reduced services. Research shows that women are paying increased attention to their use of contraception and are favouring more longer-acting contraceptive methods that tend to be more effective because of the pandemic. But we also know that in the UK especially, access to these more effective long-acting contraceptive methods such as coils and implants often need a face-to-face appointment, which have largely been suspended, as these often require a face-to-face appointment, or which are being replaced by phone and video calls to kind of impede the spread of corona. So we may actually see a rise in unplanned pregnancies due to the kind of access to kind of contraceptive methods and women's usual methods of contraception. On the other hand, women who are planning to have children through fertility means have also had their journeys to have children massively disrupted by the pandemic. In March last year, fertility treatments such as IVF, which are used to help women and couples have children, were suspended, creating a significantly distressing time for those who were in the middle of their journey of conceiving or just about to start their journey. Clinics reopened in May, but the restrictions on treatment still apply today in order to maintain safe practice for both staff and patients. The postponement of treatment has created a really significant kind of time pressure for many women, particularly older women whose chances of successful treatment are already lower. Delays of even just 6 months to treatment, especially for older women, reduces IVF success, which was kind of the case for some women. And it also means that if treatment is delayed and a woman passes a certain age, this now means that they're not eligible for treatment and therefore miss out on their chance of having IVF altogether. So just to round up really quickly, this speculation of a baby boom that we saw at the beginning of the pandemic assumes that women are able to get pregnant as they choose, but the pandemic has created a really complex environment, leading women to make really difficult decisions about their reproductive lives. Some women may be waiting longer to have children, have an unplanned pregnancy, not get a chance to have children at all, or abandoning their fertility plans altogether. And as Parved mentioned in his introduction, it's really important to pay attention to the kind of intersectional impacts that the pandemic is having on women's reproductive plans. So that's me. Sorry if that was a bit rushed. I'll now pass on to Ross. So thank you very much.
Thanks very much, Sasha. That was really interesting. I'm just going to try and share my slides with you now. Thank you very much. My name's Ross Little and I work here as a senior lecturer in the Division of Community and Criminal Justice here at Montfort University. And my teaching focuses on children in the criminal justice system, and my PhD research focuses on educational opportunities in prison environments. So here on World Health Day, I'd like to just spend a few minutes in this speed lecture raising awareness about solitary confinement of children in prison. And in doing that, I draw on an article I wrote for the National Association for Youth Justice during the first wave of the pandemic. Almost a year ago now. It was published in May 2020. And some people have compared our experiences of lockdown to imprisonment because we've had our liberty taken from us and our daily patterns have been forcibly interrupted. And whilst this comparison is understandable, I'd argue it's at best incomplete and at worst misleading, particularly if we're considering the imprisonment of children. Individual circumstances differ, but by and large, you know, most of us are able to speak with others on the phone when we want to, or play a game online. We can leave the house for exercise, or help a neighbour. We can eat what we want when we want within the limitations of budget and what's available in our stores. But that's very much not the case for people in prison, and particularly for children in prison. So the COVID-19 kind of pandemic has kind of given us a taste of these restrictions on our liberty, but just to emphasize that lockdown in the community is fundamentally different to imprisonment. And in relation to solitary confinement, it's in her sourcebook of on solitary confinement, Sharon Shalev has illustrated how, with the exception of the death penalty, solitary confinement is the most extreme sanction which can be legally imposed on prisoners. So it adversely affects the health and well-being of those subjected to it, and the consequences can be very serious, particularly if experienced for prolonged periods. And Shaylor's research finds that there's been an increase in the use of strict and often prolonged solitary confinement in prisons and other places of detention across the world. And this was even before the pandemic struck. And what we've seen is the pandemic and the lockdowns associated with it have only exacerbated some of the challenges and the harms associated with solitary confinement. And we know there's potentially harmful consequences, not only for the individual subject to it, but also for the wider communities to which the children will eventually return. Remember that most children in prison will eventually return to society. Haney's research has focused on these kind of adverse effects on health and well-being, particularly the psychological pains of solitary confinement, and some of that's focused on the supermax prisons in the United States. And he notes that studies of prison isolation have documented an extremely broad range of harmful psychological reactions. Negative attitudes and affect, insomnia, anxiety, panic, intrusive thoughts, cognitive dysfunction, hallucinations, loss of control, irritability, aggression and rage, paranoia, hopelessness, lethargy, the list goes on. And in fact, many of those negative effects of solitary confinement are similar to the acute reactions suffered by people who have been exposed to torture and trauma, such as victims of post-traumatic stress disorder. It's important to note that there's not a single published study of solitary confinement in which non-voluntary confinement for over 10 days, so that's where participants were unable to terminate their isolation at will, that failed to result in negative psychological effects. And a range of clinically significant symptoms include hypertension, uncontrollable anger, hallucinations, emotional breakdowns, chronic depressions, and suicidal thoughts and behaviour. A study of Danish prisoners found that for prisoners who remained in solitary confinement for more than 4 weeks, the probability of being admitted to the prison hospital for a psychiatric reason was about 20 times as high as for a prisoner in the mainstream population. And for these types of reasons, the United Nations Committee on the Rights of the Child recommends that solitary confinement should not be used at all against children. And in fact, that's also reflected in the inspection criteria for assessing the treatment of children in detention in this country. However, any of the current methods of separating children from their peers has the potential to become solitary confinement, and that's defined as if the child experiences confinement for 22 hours or more a day without meaningful human contact. And that's as defined in the Rule 44, the United Nations Standard Minimum Rules for the Treatment of Prisoners, otherwise known as the Nelson Mandela Rules. And when we think about, well, what do we mean by meaningful human contact? It should be face-to-face, direct, and enable empathetic interpersonal communication. It should not be determined by things like prison routines, criminal investigations, or medical necessity. And this brings me on to a case that I think demonstrates some of the issues. I'll just mention it briefly. But this is the case of child AB, who was held at Feltham Young Offenders Institution, YOI, in London. And the isolation and lack of access to education at Feltham Prison for this child, known as child AB, was found by the High Court to be unlawful in a judicial review case pursued by the legal team at the charity, the Howard League for Penal Reform. Quick note there, quick aside as well, judicial review is itself being reviewed at the moment by the government. And I think it's a really important mechanism by which citizens can potentially hold the government to account. And it was found that the UK government is out of step with a growing international consensus that children should never be placed in solitary confinement because it perpetuates, worsens, or even in some cases precipitates mental health concerns that can lead to long-term and often permanent changes in adolescent brain development. And the widespread use of solitary confinement of children in prisons in England was exposed in 2015 in Unlocking Potential, a report by the Children's Commissioner it found that 1/3 of children in prison will spend some time in isolation. And the practice is actually used disproportionately in respect of children from looked after backgrounds and ethnic minority backgrounds. And in a ruling delivered in 2015, the Supreme Court held that there are well-known risks of solitary confinement, and that prolonged solitary confinement, defined as being held for longer than 15 days, is particularly harmful. And this links in with the United Nations Sustainable Development Goals, and the importance of strong and fair justice institutions. This is now a global focus thanks to the United Nations SDGs, or Sustainable Development Goals. The objective of Goal 16 is to promote peaceful and inclusive societies for sustainable development, provide access to justice for all, and build effective, accountable and inclusive institutions at all levels. So a clear connection there with solitary confinement. Okay, my final slide. I think it's important to talk about this on World Health Day for a number of reasons. It is by definition a rather hidden issue in our society. And if solitary confinement is so damaging for child development, then on today of all days, it's reasonable to ask why it's being used for children in our society. Children are expected to be released from prison and then somehow to continue with their lives, to resettle as normal. But that's going to be very difficult if they've been subject to separation and solitary confinement. The psychologist Donald Winnicott argued that a child can learn to be alone only in the presence of a trusted adult. However, trusting relationships with adults can be difficult for children in prison to establish. For example, the most recent Children in Custody report, which was published in January this year by a Magistrates Inspectorate Probation, found that 42% of children surveyed reported experiencing some sort of victimization by staff. And children from Black and minority ethnic backgrounds were significantly more likely than children from white backgrounds to report being verbally abused or threatened and intimidated by staff. So the inappropriate use of separation or solitary confinement serves to strengthen arguments by a coalition of organisations to end child imprisonment as well in secure training centres and young offenders institutions. I did just want to end on a positive note, though. So this is kind of call to action for us to pay attention to more to the research that highlights the health problems associated with solitary confinement. But within the last week, actually, I've learned that New York will actually be ending the long-term solitary confinement in prisons and jails. So isolation for more than 15 consecutive days will be barred in both prisons and jails there, starting from March next year. And importantly and relevant for this presentation, it also bars the practice entirely for children and for people with certain disabilities as well. So I'd like to just conclude by saying that solitary confinement for children and indeed adults is not inevitable and is ultimately not necessary. And so on World Health Day, just like to encourage our society to reconsider the research evidence on the use of this practice. Thank you very much for listening. I hope I haven't gone over by too much in terms of time. And it's my pleasure now just to hand over to my colleague Ngozi Kambashi, who will be talking about the perceptions of male rape.
Hello, thank you for joining me today. Today I will be talking about the perceptions of male rape and the impact of COVID-19 on the perceptions of male rape and the impact of COVID-19 on my research. So I would just like to start with a little bit of background as to the perceptions of male rape, and then go on to the impact on the research and then on the actual health of the men themselves. So I'll just start, okay, I'll just change the slide now. So, okay. So literature on male rape myths has demonstrated that when people have an idea of how rape typically occurs, This idea is that a stranger violently attacks a woman walking alone at night. A man being a victim of rape is a departure from the script, and this can lead to people believing false perceptions about how rape typically occurs for men. These are also known as male rape myths, and they function to deny or minimize the experience by shifting part of the blame or all of the blame from the rapist to the victim. This blame attribution can be influenced by things such as gender and sex roles, homophobia, lack of reporting of the crime, as well as other belief systems. So I've got here on the slide some of the myths that have been in the UK. So I'll just briefly go through them. So all men should be able to avoid or prevent being raped. Only heterosexual men are the real victims of rape. The victim must have behaved or appeared in a way that signified that they were gay, which leads on to the myth that because they were gay, they made up the false allegation to cover up a consensual act. Apologies, I'll just go back one. Going too fast. Right. So acceptance of these myths is damaging to survivors and wider society, which just suggests that anyone can be accepting of these beliefs, and this can lead to people reacting negatively to survivors who disclose their experience to them. The adverse reactions may result in secondary victimizations for the survivors. Secondary victimization to the survivors can stop any further attempts for survivors to seek support from support services, law enforcement. They may even stop speaking to their friends and family about the incident. Additionally, we have to remember as survivors are part of wider society, they can be aware that these myths already exist, thus they may not be likely to report or seek any help from any support services or law enforcement. And this in turn can result in the low reporting of male rape myths, male rape that we're seeing reflected in the statistics. So then, which leads on to the low reporting of male rape myths can mean that unfortunately there will be less service provisions given to services that support men. And so this leads to lack of resources. So all these factors, the factors of male rape myth acceptance and lack of resources for male survivors, can compound a male survivor's physical and psychological well-being following the rape. I'll just move the slide now. So I'm in the process of conducting research into professionals, survivors, and community perceptions of male rape myths by examining their perceptions of male rape. So I'm doing this in efforts to attain an up-to-date understanding of male rape in the UK, with focus on barriers to help seeking, sexuality, and gender. It is hoped that my research will bring awareness to the issue of male rape in the UK. So, but when I started looking for participants, I was faced with some issues due to COVID-19. So I started to ask for gatekeeper permissions in May 2020. And some of the organizations I contacted to ask them if I could recruit professionals from their services told me that due to COVID-19, they did not have the resources to support the much needed research at the time. So then I waited a few months, and in November and December 2020, I sent up follow-up inquiries to the organizations who didn't initially respond to some of the emails. And then they disclosed that from the initial contact with me, they were very busy and just could not reply at the time. So the busyness of the organizations was anticipated, as we know, support services for both male and female survivors of rape and abuse had to close at the first lockdown, like most organizations did. This meant that this period services were limited to emergency telephone contact only, whilst they transferred their services to online and telephone settings. In the same instance, the incidence of victims contacting charities for support had increased, with one domestic violence charity reporting that male survivors contact had risen to approximately 96% from pre-COVID times. So that was from June 2019 to June 2020. This meant that the already limited resources for male survivors of abuse, including rape, had to accommodate the increased number of contacts. Whilst another male charity reported that some survivors preferred seeking help via Zoom and telephone, as before the pandemic they were unable to attend the service in person. While other survivors stated that they preferred the privacy the face-to-face interactions provided, because during the lockdown they did not have any space or anywhere they can go to be alone and to speak freely about their issues. Though it's looking like in the coming months, some charities will be able to open for in-person contact and keep their new working online settings. Right. So despite the increased domestic violence, which includes sexual violence towards all genders and ages, the current campaigns to tackle the issue of increased domestic violence during the pandemic only mentions women and girls. This arguably is continuing the marginalization of male survivors during the COVID-19 pandemic. As the question remains, how likely are men to come forward during this time if the campaigns do not represent them as well? Additionally, the lack of mention of male and non-gender binary individuals in the campaigns to tackle domestic violence arguably maintains the current misinformed discourse that sexual violence only occurs to women and girls. The lack of inclusivity violates the Sustainable Development Goals, peace, justice, and strong institutions. I think my colleague Ross also spoke on this, but I'll be speaking on it on particularly the target of 16.1. This target aims to significantly reduce all forms of sexual violence and related deaths everywhere to everyone. So this applies to the health of male survivors because the language used in the campaign to reduce domestic violence is not inclusive to everyone. So I will just go on to now the last slide. Right. So I refer back to my research. So some of the preliminary findings from my research is that the professionals are reporting that sexual violence usually occurs at home, behind closed doors, by someone we know, by someone who's known to the victim. So this then really highlights that ideally in these campaigns to tackle the domestic violence, the language should be inclusive to everyone and not just a particular population. So I am hoping that the findings from my research will generally bring the issue of male rape into the discourse of rape in the UK. The next phase of my research is to interview survivors themselves, and it is anticipated that during the natural discussion, the issues of COVID-19 and how it's impacted them will come up. I'm doing this because it's shown that research into female rape myths has demonstrated that awareness has led to positive outcomes, including needs-based informative resources that are specific for female survivors, and survivors feeling more confident to come forward and seek help post-assault. So thank you for listening. That's been my lecture, and back to you, Barbara.
Thanks very much indeed. 3 wonderful lectures, and now we have some time for asking some questions, which each one of you can ask the other if you like, but I will also have some questions to ask as well. And so I think I will start off by asking Sasha, a very interesting presentation. I mean, your research is really exciting. And, one was expecting there would be a baby boom. And it seems like we're having a baby bust. And I mean, it's very sort of like opposite of what one was expecting. But in some countries, I heard that in Germany, what was happening was that actually they had an increase. There was a baby boom actually during December and January this year. They had more births in certain parts of Germany, especially the richer regions. Actually, they had an increase in birth, and they do have in Germany certain positive sort of like benefits for having children, like they give long parental leave and so on. So tell me, I mean, is this a baby bust, baby boom across the society? Was it something from your research about the subject equal, or, I mean, in the UK there has been a decline, but has it been a decline in all parts of the country, or some regions there was an increase? Is there any statistics associated with that?
Yeah, that's a really interesting question. There's not enough research, unfortunately, where we can kind of decipher between the regions yet. I'm sure that's coming. But the effects of COVID on fertility is definitely country specific. And that relates to kind of social, economic kind of factors. So some research suggests that in the UK, we have much more of a precarious kind of economic environment, which is, which existed before COVID. And this is, obviously the pandemic has kind of exacerbated those kinds of issues. So in other countries, you're right, we may see, or we have seen in Germany, that there has been a rise in fertility rates. And that may be because their kind of environments are less precarious and their economies maybe not as affected. And so people aren't feeling that kind of pressure to kind of have economic stability or have as many concerns about their economic stability in the future. So it's, the research is kind of emerging. A lot of it at the minute is kind of anecdotal evidence. Hopefully we see how this impacts countries, different groups of people. Like I said, it's really important to pay attention to the intersectional kind of impacts of COVID. So yeah, I think that will be something really interesting that research should kind of look into. And I think regional would be particularly interesting in the UK. And also my presentation is kind of, I guess, one-sided. There are other reasons why people may have children and when they weren't planning to. And I've presented the kind of baby bust side, but there are definitely reasons for why people may decide to have children if they weren't planning to already. So, it's all kind of it's fairly anecdotal at the minute, and we're still not out of it. So that there'll be plenty of research, I'm sure, that kind of contributes to those questions.
Yeah, absolutely. I think we do know that, for example, in the UK, life expectancy can vary between different regions. For example, if you live in Surrey, in London, you may live up to the age of 85. But if you are living in the northeast of England or in Glasgow or Merthyr Tydfil in Wales, then maybe you will die at the age of 70, 75. So there is a big sort of difference in longevity. And perhaps even the German data, which I sort of like came across, is that the place where they had a 0.8% increase in birth rate and so on was in that part which was very rich area of Germany, whereas in the eastern part of Germany there was actually a decline. So we may find in the UK, I guess your study is obviously focusing on the UK, you may find that within regions, within areas, you will have differences between having a lot of children or not, and so forth. So very interesting. I wish you all the best with your research. It's exciting, a lot of things to do. And I think did you start this project on COVID-19 well in advance, or is it something that you adjusted in and seized the opportunity? What was it?
The latter, yeah. So I'm actually nearing towards the end of my PhD, but the main premise of my PhD was to focus on how women evaluate the ideal timing of childbearing and motherhood, when they feel is the right time, what factors they feel are important before having children. And I've used kind of my findings and kind of tried to contribute to these understandings of why, you know, what are the kind of social implications, the individual kind of differences around childbearing planning during a pandemic. So I didn't unfortunately get to ask women because I'd done my interviews before the pandemic. So I didn't get to ask how that's shaped their perceptions of reproductive timing, but definitely my findings can inform these kind of conversations, and I think I'd like to do another PhD on that kind of subject if I could, because it's a really interesting and complex. You know,
maybe postdoc. Maybe you can do postdoc research.
Yeah, maybe.
Yeah. Thanks very much. I have a question for Ross. Very exciting, you know, sort of research, and focuses on a very vulnerable group, you know, children and prisoners and so on. You said something that in the last 5 days, or in the last few days in New York, they actually they will no longer have solitary confinement more than 15 days. So, I mean, why do you think there's 15 days? I mean, the point I'm trying to say, to get at, is that if solitary confinement is not a good thing, and if these prisoners are one day going to be back in society, even 15 days might have some impact. When is too many days for being in solitary confinement? Is there any sort of like research done to say human beings should not be left somewhere for more than a certain number of days alone?
Yes, it's a good question. I mean, I think some people, some actors, if you like, in New York, I don't mean film actors, but have wanted for some time to restrict or abolish the use of solitary confinement. So I think it's not something. It's something that's just been announced, but I think it's been something that's been ongoing for a while, and also had some resistance, I think, not least from the serving governor, who it's quite interesting how he's changed his mind, I think, due to public pressure. So I think the 15 days is a kind of a standard kind of indicator, but I think how an individual reacts to solitary confinement can vary to quite a large extent, and you see a range of kind of negative side effects on health and well-being. And depending on which one of those you focus on, you'll see that kind of expressed by something like 90% of human beings, right down to perhaps more like 20% of human beings. So there's quite a lot of variation, and it will depend on a number of different contexts, not least other elements of a regime. So I think it's, some studies focus on 10 days, some are focused on 15 days, and some are focused on longer periods, such as 4 weeks, like in the Danish study. So I don't think there's any kind of hard and fast, period. It is quite different for different individuals. But that roughly 2 week period has been, I think, used most frequently in thinking about the deleterious effects on health and well-being, and most people will experience longer term impacts from solitary confinement of longer than 2 weeks. I mean, some people will struggle after very short periods. 24, 48 hours can be enough for some people to exhibit some very negative consequences of solitary confinement. I personally think that I would struggle quite a lot. I think probably most people I know would as well, because we're kind of socially conditioned that way, aren't we? As well to seek out contact in our work and our social lives. So I think it does vary for individuals, but I think it's a reasonable indicator. I think some people, including the researcher I mentioned, Haney, in the US, has said, well, I think that New York could go further in this. But it's certainly a very positive start. and something that many people hadn't foreseen. And interestingly as well, it's not actually going to start for another year. I don't know why they couldn't have started it in the summer, for example, or next week, really. But I think they probably can go further. But I think that 15 days is I think there's probably pressure from staff groups as well. Some professional associations, they see this as a way of protecting staff. The irony is, of course, is that the use of solitary confinement has increased at a time when the prison context has become more overcrowded and more violent. So I'm not sure that it's much of a solution, but it's been used. I think it's symptomatic of other things that are going on elsewhere in the prison system.
Yes. Do you think that, I mean, human beings are very social people. Normally they will go to, various, community centers and activities, whether it is people are going to the pub, whether people are going to their places of worship, sporting venues and everything. So there has been a lot of interaction between human beings for long, and for more than a year, we have been out of it. Do you think this one whole year might be having an impact on us, that we are becoming, some of us might become adjusted to be living alone and not being in contact with others, no face-to-face contact for a long time, and so we slowly become antisocial, let's say. We actually lose our ability to, we even enjoy the company of others. We become adapted to this way of living. Do you think this is a risk for some people?
Definitely, yeah. I think from a personal experience, I think perhaps for a period of time I was in denial about the impact of the lockdown associated with the pandemic, and I do think that people do have the potential to become more antisocial and see social interaction as much more effortful and much more of a problem, something that they're almost becoming, some people will become fearful of. And I think people that spend long periods in prison become institutionalized. And I think this is particularly problematic for children, who I think can become institutionalized in over shorter time periods. We think about the summer holidays, 6 weeks used to feel like an eternity. But I think that it, so how kind of perception of time is quite interesting. I do think these periods of solitary confinement are particularly damaging for children, particularly because, let's say you're 15, 16, 17, where are you getting? You're increasingly moving away from your family or your guardians as the source of your kind of social input. You're moving more and more to interact with your peers, and you're going out, and all of the things we associate with healthy development. For children in prison, they quite often experience this period of arrested development, and their lives are not moving on educationally, socially, health-wise, in terms of relationships with the same sex or the opposite sex. And I think that's particularly, it can be particularly damaging. So yeah, I think there's broader impacts for society in terms of lockdown. But I think there's particularly harmful effects for imprisonment in children, solitary confinement for children, and solitary confinement during a pandemic as well, which I think has become even more used based on the information we have so far.
Yes, it's sad. I think what we're doing is really creating more problems for ourselves in the future. So, those children of prisoners, they are already perhaps obviously not getting the support they need. Maybe they never had the support that they needed, even when their parents are around. We don't know maybe what the circumstances were. And then when the parents are in prison, they're even more deprived in terms of social interactions and support and guidance and so forth. So, in a way, what we are actually doing is, making their situation worse, which in due course will make the whole society suffer as a whole. Not only those children, but the whole society will suffer if these people are not going to be good citizens who can be happy and at peace with themselves and with their surroundings. Then we are actually creating more problems than solutions by doing these sort of things. And I think it's sad that in this 21st century that we are not thoughtful about the strategy that we are applying. And like you said, only a few days ago that they're thinking about changing this idea of solitary confinement for longer than 15 days. I mean,
yeah, I'd be inclined to agree with all of that. I think we need to remember that on really many measures, children in prison are amongst the most vulnerable in our society. So they do tend to have experienced multiple episodes of disadvantage and trauma in their early lives. That's not to excuse criminal behavior, but it is to seek to understand it, I think. And a punitive response doesn't start to address some of those difficulties. We know that a very high proportion of people in prison are children that are looked after by the state. We might say looked after in inverted commas, but you know, they're children that are there. So just, yeah, it's a very high proportion. We know that we've got a very low minimum age of criminal responsibility in this country, which is 10 years of age, and that does contribute to this problem to some extent. So yeah, and there is room for optimism in the sense that fewer children have been going to prison for over the last 12 years or so than previously. This time 12 or 13 years ago, we might have had 3,500 in prison, children in prison at this point in time, whereas now we're looking at more like 500 or 600. However, for those children that are in prison, they are experiencing higher levels of violence in the institution, high levels of assaults between themselves and towards staff, and high levels of self-harm as well. These things are associated with confinement.
Thanks. I'll come to Nagosa Kambashi now. Very interesting, very interesting presentation. So, you know, this is a subject which must be quite difficult for you in terms of finding, because you need to, for your project, you need to have a lot of people volunteering and you need participants. I think I can hear some echo. Is there some? I don't know. For some reason, it's fine. So are you able to get enough participants? I mean, especially the male rape victims. Are you sort of like doing questionnaire or interviews in your research?
So what I'm going to do is I'm going to aim for interviews to speak to about maybe 15 to 20 participants. But that's currently going through ethics at the moment, so we'll see. But I'm optimistic because I've got some charities who already are willing to facilitate this process to help source these survivors. So fingers crossed.
Yeah, is you know, male rape incidences going up in the UK? It is sort of like, I mean, do you know the trend? Is it decreasing, increasing? I mean, what's happening in terms of, is it going up? Statistics wise?
It's going, whether or not it's going up, it's more so, are people more willing to come forward? So it takes on average about 20 years for someone to experience the incident, and then 20 years to actually report it, talk about it, disclose it, seek help. So we are starting to see some of the statistics going up, but it's whether or not is the actual incidence of the crime itself going up, or is it just more people feeling more confident in coming forward as they see themselves more represented in the media? Yeah, so in terms of that, I think it's a bit early to tell. In terms of male rape is about 20 years also behind from female rape. So it'll be interesting to see whether what the female rape literature has found and whether or not this will be replicated with the male rape literature. But in terms of how to see the difference, is going to have to unfortunately take some time to do that.
Yeah, thank you. I think we can now move on to questions and answer session. Unless, do you have any questions to ask each other? Because this is panel discussion, so I mean, feel free to ask each other questions if you like. I've asked enough questions. I think some of you can feel free to ask a question to each other. Yes, Ross, I think you have a question to ask.
Yeah, it's just a question for Ngozi and her research, really. I wondered if about the settings in which people tend to disclose rape as having taken place. And I was just thinking about the different settings in which that might take place, whether that's kind of public or community settings, family settings, or more institutional settings. And I just it was just a question that occurred to me about that, and whether her research or other researchers has looked at that.
So what I'm hearing from the professionals that I've already spoken to is that they're more likely to disclose to a charity. So in terms of like seeking psychological support, therapy, maybe even some group work as well. And then from then on, they may actually come to a point where they are ready to now make the report. So the report is not always the report to the police is not always instant. You normally comes after some time of therapy and even just some support. So I've been working with male survivors myself for quite some time now, delivering emotional support, and you can just tell the difference. Is the more they talk about it, the more they feel confident, the more they want to then disclose and let other people know. And I've spoken to some other charities, and most of them normally what they deal with is historical cases, and it'll be interesting to see sort of what rights the survivors have on historical cases. I mean, it shouldn't be too much of a problem in the UK because I don't think we have a statute of limitations like America does. But yeah, so going back to your question, it normally starts with people seeking support from charities, then moving on to law enforcement. On rare occasions, if the incident has been violent enough to the point where the person is very hurt, they more likely to actually go to accident and emergency and go through that route because they feel like they now have proof that this incident has occurred. But as I said, that's very rare, very rare. Thank you.
Thanks for that. I was just, I think I've got so many questions about it. I was also wondering about trust in terms of reporting it to the police, for example. I know that can be an issue for anyone that's experienced rape, but I'm just wondering if this is a particular issue, perhaps in relation to survivors of male rape. I don't know.
At the moment, I'm not too sure about between the trust between survivors and the police officers. But what I am hearing is that it goes back to even before you get to the police officers. If we look at the definition of rape in the UK, it's only men who can be perpetrators of rape. So some of the survivors may feel or may not able to legally define their experience as rape. Therefore, they may not feel like they are entitled to any support, or they won't know what kind of crime this will be. So it really starts from there. Really, the gendered legislation we have in the UK on who can be a perpetrator. There's literature that is definitely in America and even in Mongolia and Zimbabwe and South Africa that has shown that for survivors who have experienced rape from a woman is equally as traumatizing as if it was for a man. But unfortunately, the UK does not recognize that. So in terms of men then feeling like they can trust or come forward to even report this incident, which they feel is rape in the UK, at the moment that's not even possible. So I think there's a lot of work to do there. There is a researcher currently, Siobhan Ware, who's looking at possibly changing that legislation. So that will be interesting to see how that comes forward and whether or not that will improve the trust between survivors and law enforcement themselves. Thank you.
Thanks, Dagosa. I think we have some questions from the audience, and there is one question for Sasha, and this is from Professor Deborah Cartmel. And her question is, I think you can see that on the private chat actually. It says, was there a gradual decline in birth rates since March 2020, or is this consistent across the entire period? I wonder if it reduced as time went by, as people felt increasingly uncertain.
Mm-hmm. We don't know that for sure yet. Demographic kind of data on fertility tends to lag after an event, and obviously COVID is still kind of going on, so we won't know the true effects of this yet. But demographic research is kind of starting to look at it, to look at this and how fertility is kind of is being impacted. There's a working paper from a group in Southampton that are looking at the kind of demographic changes, and that will be really interesting to see. But it's also important to remember that fertility rates were declining before the pandemic. In the UK in 2009, the fertility rates were the lowest they've ever been. And women are having children at later ages than ever before. So it will be hard to kind of decipher, on an individual level, who is declining because of the pandemic, who women are just declining or delaying or not having children at all because of their own, regardless of the pandemic. So it'll be a really tricky kind of, finding to analyze and kind of work out, and that's where kind of social science comes into play to find out what our individuals' experiences about these things, what are their feelings and experiences of having children and in the pandemic, and how that will play out. But we're still, it's been a year, but we're still very much in the thick of it. So I think it'll be really interesting to see if it was a kind of gradual decline or whether there was a kind of sudden stop. I know there is some kind of anecdotal kind of opinions that, people see kind of no end to the pandemic, so they may be getting back on track with their childbearing plans, just because they don't know where we'll be in a year from now. So let's have them now, because, we don't know what the situation will be like. On the other hand, as I said in my presentation, there are various really complex decisions around, financial status, health, psychological kind of readiness. So it's a really complex kind of set of questions, I guess, and hopefully kind of research starts to illuminate how it has really impacted fertility rates. But they were declining anyway, so it will be hard to kind of decipher what the pandemic has caused and what is kind of naturally happening anyway in terms of fertility.
There's another question actually thanks very much, Sasha, very detailed answer. Another question from Professor Deborah Cartmel, and this is for Ross. So what she's asking is, what do you propose as alternatives to solitary confinement?
Okay, yeah. Well, thanks for the question. It's a good one.
Yes.
I think in part it's about understanding how we got here in the first place. I suppose we can think about the wider context of the Fifth Justice over the past, let's say, 70 years or so. Let's say the post kind of Second World War period. In that period, we've seen our responses to law breaking by children kind of ebb and flow to some extent between more kind of punitive type responses and more welfare oriented type responses. And we saw the prison population for children grow quite a lot in the early 2000s, which happened in response to, I think, concern about broader crime rates in the general population, a concern about antisocial behavior, and a political kind of rivalry between the two main political parties that both wanted to be tough on crime. And to some extent, children got scapegoated in that. The law changed in 1998 to effectively bring the minimum age of criminal responsibility down to 10. And as I say, in the early 2000s, we saw this considerable increase in the number of children that were brought into custody and serving prison sentences. And so we see we have seen these more punitive type responses as appropriate, and solitary confinement is kind of almost like the logical extension of that, to get tougher on prison, to extend the punitive element of prison. Well, what's even worse, it's solitary confinement. Now, of course, you may need to isolate some prisoners and some children for very short periods of time. But I think I would argue that the use of imprisonment should be minimized as much as possible. And we have seen that it can be reduced considerably. I'd argue it could be reduced even further. We've got this, when we think of people breaking the law, we've got this kind of quite dominant image of imprisonment in our head. And I think we probably could do with losing some of that. We automatically think about punishment. And in terms of punishment, we automatically think of prison. It's been sort of culturally ingrained in us for about the last, prison's been around in its current form for getting on for 200 years, but it's something in the last generation or so that has been our default response, I think. So I think we need to do something about that default response. And I think we can imprison fewer children. And as I say, we've been doing that already. And so I think we can use it a lot less, see it as less acceptable from an institutional perspective, less acceptable from a social perspective as well. By and large, many of these children don't really need to be in prison in the first place. And as I say, I mentioned it briefly in the presentation, there is a campaign to end child imprisonment, particularly amongst secure training centres and young offenders institutions. We've got quite a complex arrangement for custodial arrangements in this country for children. So we could, abolish those forms of imprisonment which are not really suitable. They're not really addressing the needs and the issues of the individuals who find themselves in the criminal justice system or wider society. So I think we have seen a growth in what some people refer to as robust community alternatives, the use of curfews, electronic tagging, supervision in the community, different forms of reparation and restoration. I think each of these have to be examined quite carefully in their own on their own terms. But I definitely think there's a lot of scope to reduce the use of solitary confinement for children and adults. And as I say, I mentioned towards the end, New York has shown that very recently. But they're not the only state in the US that's had a change of. I mean, in the United States context is quite interesting because they saw a huge increase in the number of people imprisoned between the late 1970s and around 2010. But they've been rethinking that approach. More violence, whoever's inflicting it, in this case it's the state, just leads to more hardship and violence. It doesn't really solve the underlying problems, which tend to be quite deep-rooted and complex. So I don't think we should give up on those other solutions. There may be a very small proportion of people that do need to be imprisoned, but this should only be for the shortest period possible. And one last point is what we've actually seen is over the last 20 years or so, we've seen the length of life sentences increase quite dramatically in this country. And so this is all happening in a broader social and political context, I think, that we need to understand and appreciate.
Yeah, thanks very much. This is very interesting points, and I hope Deborah is happy with your answers. And I feel sometimes we don't sort of integrate the research knowledge in policy making in a comprehensive way. And I mean, I just give you an example. I don't know if you recall, during the time of John Major, there was a policy which said that any children that were seen outside after 9 p.m. or something like that. I can't remember. It just came to my mind because of your presentation, because it's not a subject I've been thinking about deeply. But I remember at that time there was a rule that any children who go out and wander around in the streets after 9 p.m., like there should be a curfew, they should stay indoors. During the same period, almost overlapping, was a promotion of the idea that all parents, single parents, whoever they may be, they have to go to work. They have to work. Fine, that's good. You have to go to work. But how are they going to be able to keep the children at home if, for example, they're working in the evenings and so on and everything and so forth? So there isn't a comprehensive analysis of how to deal with all these issues. And it's so complex. And I was just wondering, one of the things that I mentioned at the beginning of the introduction is, one size does not fit all. And since we now live in the age of big data, surely, like you said, for example, the prison number of children in prison has decreased from before to now and so on. Can we not use big data? Can we not use artificial intelligence in order to identify what are the root causes of the problems, and how to sort of identify where the problem lies and deal with them so that it does not become a big problem for society? Why aren't we doing that? If we can go out to the space to look for life using artificial intelligence and so on, why can't we use all of this big data to look for these inequalities in health and identify who are the ones who need the most help and support? I mean, any one of you, if you have any ideas and suggestions about what you think, I would like to hear your views, and the audience, I'm sure, would like to hear as well.
Just on that, Parvez, I was going to say, I think you'd need to care first, wouldn't you? You need to care about those kind of social inequalities to do something about them. And there has been this big disconnect for quite some while now between the research evidence and policy making, which was your starting point there. And I think that surely over time they have to become more closely aligned. Yeah, so I think that's all I'd say on that, really. But I there's a number of things I could say about curfews and antisocial behaviour, and we've got to be careful about not widening the scope of the criminal justice apparatus too much. I know that some of those issues you mentioned, some of the most vulnerable children are not being supervised at home, and that they can be vulnerable to all forms of a number of forms of exploitation actually in society. So but that is the whole kind of, it takes a community to kind of raise a child type approach, isn't it, really, I think. But yeah, that's probably it for now.
Yeah, I think you summed it up. We have to care. I mean, the thing is, there is a lot of research, there is a lot of data, but at the end of the day, this will only get implemented if people really care about these issues, strongly enough. And I think as researchers, all of the research that we are doing hopefully will inform the politicians and others, and they will seriously look into this. I'm sure they have good intentions in their hearts, and as researchers, we also have good intentions, and I hope we'll work together to solve the problems that we have in society. And so once again, I like to thank you all. Sasha, thank you for your wonderful presentation. I wish you best of luck with your PhD, and maybe another PhD, or maybe postdoc, whichever. There's a lot of interesting things to be done in your area. And Gosha, very interesting work that you're doing. I wish you all the best for your project, and I hope you manage to get things done. It's a challenging project, but it's a very interesting project. I hope you manage to get your data. And Ross, thank you very much for your wonderful ideas and thoughts and suggestions. I hope your research goes well, because I think it's important actually, and hopefully it will make our society a better place, because this is the type of research and thoughtful thinking that I think can make a difference for all of us. And without further ado, I would like to say that once again, thank you all. Whoever is watching this online webinar from wherever you are, we wish you a safe life, a healthy life, and take care, and all our best wishes, and maybe we'll meet again somewhere in the future. Thank you. Bye-bye. Bye-bye.
Thanks very much.
Bye-bye.
Bye. Thank you.
Thank you. Bye-bye.